CivicCon is a partnership with the Pensacola News Journal and the Studer Community Institute to make our community a better place to live and work and play and invest through smart planning and civic conversations. Throughout COVID, we've been able to maintain our civic conversations and our schedule, and the input that you provide at the end of tonight's session is input that we use to plan future events. So please take the time to fill out that very brief, it's like 60-second survey so that we can get all the info we need to plan some future events. I'm Lisa Nellison Savage. I'm the executive editor of the Pensacola News Journal, and I'm so excited to have with us tonight Jill Miller, who's the president and CEO of Bethesda Inc., an organization that is both co-sponsor of TriHealth and creator of BI3, a grant-making initiative to transform the health and well-being of people of the greater Cincinnati area. BI3 makes philanthropic investments, more than $53 million since 2010, in TriHealth and in community partners to fuel innovative ideas and reduce health disparities. Under Jill's leadership, BI3 has grown in size and scale, co-designing health initiatives to solve communities' health issues such as infant mortality and working to shift the power dynamic between funder and grantee to accelerate change. Jill is most proud of the fact that nearly 200 babies are alive today due to the collaborative efforts BI3 has funded to reduce infant mortality in Hamilton County, Ohio. Earlier today, Jill met with many of our area's nonprofit leaders to discuss the grant-making process and how she goes about ensuring that that money is spent wisely, including how to hold grantees accountable to measurable change. Tonight, she is going to focus on health disparities and how hospitals and communities can work together to ensure all people have an equal chance to achieve good health. Please welcome Jill Miller.
Thanks, Lisa. Thank you for that warm introduction, and I have to say it is so great to be in a room with people. And I know many of you are tuning in via Zoom or live stream, but it really does add something to a presentation when you have real people in the room, so thank you. As Lisa mentioned, I am president of Bethesda Inc., which is a co-sponsor. You can think of us as a holding company of a healthcare delivery system in Southwest Ohio. And we also have a grant-making initiative called BI3. I've been president and CEO for nearly 7 years, and I thank all of you for being here. And over the next hour, really hope, I don't have all the solutions to health disparities. They're complex and they're hard to solve. But what I do look forward to sharing with you is how we are looking at health disparities and some of the projects and work that we have underway to get to some of the health disparities and the deep-seated community health issues. So I hope to provide you with some ideas as you look at your own health disparities here in Pensacola, and hopefully inspire you to come together in new ways. So what I will mention is Bethesda has been in the healthcare delivery space for 125 years. So health and healthcare is near and dear to our hearts. We are a mission-based organization, a nonprofit, so our hospital TriHealth is rooted in that mission of delivering care and caring for the community. We have, as Lisa mentioned, awarded 53 million grants over the past decade, which makes us one of the state of Ohio's largest health funders. I thought it would be great to hear a little bit more about the work of BI3. And in case you're wondering, B is for Bethesda and the I is for innovation, investments, and ideas and impact. So it is BI3.
BI3 is Bethesda Inc.'s grants initiative to transform health. BI3 is not a foundation. It's an initiative that Bethesda Inc. has chosen to launch, recognizing that people need resources to think differently and try new things.
That fundamental shift in our community that will lead to better health outcomes for everybody.
With the Patient-Centered Medical Home Grant, the goal was to change the model of care within TriHealth as a system. We were the first group of primary care doctors to adopt this as our standard way that we were going to provide care. And not only TriHealth, but the other health systems in town and some of the independent groups in town were able to adopt a similar model.
We take a mother who had a higher risk of having a baby born premature, And a mom walking through our door a year ago had a higher probability of experiencing that. Now in today's world, take that same mom in our practice, working with our providers, working with our caregiver in a solid team. They now have that support in a big way, and we've reduced the probability and the likelihood of a mom not getting the resources that she needed.
First Step Home is a program for women in recovery for drugs and alcohol, and we allow the children to live here with the moms up to the age of 12.
It's a pilot program to not just bring mom and baby together after birth when everybody's healthy and sober, but to keep them together in delivery, even if mom is still in treatment.
We've screened 11,000 families in the last 2 years, which is pretty phenomenal. We've connected over 2,500 of those families to a parent specialist. And then we also track and see what the impact of that parent-coaching relationship has been to reduce stress in the family and to build resilience. And all those outcomes are really positive.
They enable parents to have the tools to function in these really frustrating moments, and that gives the parents confidence, and they feel like better prepared to enjoy time with their kids.
What Start Strong was a really intensive effort with a whole variety of partners, where the partners came together along with, really importantly, lots of leaders from that neighborhood, and were able to just have transformative impact thanks to the investment of BI3. After decades of high extreme preterm birth rates, there was a 3-year period without a single extreme preterm birth in Avondale.
We're really training the next generation of providers to focus on serving the whole patient, not only looking at their immediate medical needs in the office, but also what are the things that are impacting their health outside of the medical office.
Legal help at prenatal appointments is showing good outcomes when it comes to healthy moms and babies.
If a mother cannot feel safe and feel comfortable going to a home and an environment where she knows she has the basic needs, whether it's heat, electricity, food in the home, a safe place to sleep at night, not thinking about getting evicted, we know that's going to lead to better care.
It excites me to leverage the work and the learnings that we've achieved to date to do more, to do it better.
And we've got work to do. In this community in Cincinnati, we know that there is work to do, and we are committed to it. And BI3 support allows us to execute on that commitment.
I envision a day when Greater Cincinnati is one of America's healthiest communities. A day when every baby born here has equal opportunity to achieve their highest level of health and well-being.
And that truly is my why. I get up every day thinking about there's 200 babies alive today because of the collective work we've done over the past 9 years. And that is my why, that more babies are alive today. How do we think about our work? And then I'll move into the health disparities piece. At BI3, our overall aims is to improve health for all people and to reduce health disparities. And how do we do it? We have 3 buckets of work. One is always going to be fueling that innovation and transformation within our partner healthcare system. But we really challenge them to move beyond their hospital walls and partner with community-based organizations. And BI3 has really become that conduit. Community-based organizations can reach out to us with their ideas, and then we can help contact the right person in a major healthcare system with 14,000 people, connect them to the right person to start to unpeel this idea and see if it'll work. So otherwise, a community organization doesn't even know how to contact the healthcare system or who to start with. So we really try to be that conduit of building important partnerships. Another big piece of our work that's foundational and we continue to build on is maternal and infant health. And I can share with you that in Hamilton County, infant mortality, we rated number 2 as worst in terms of infant mortality. What I'm excited to share with you is today we've now moved to 50 on that worst list. So I'll take 50 over number 2. But we continue to build in that space, and I'm going to share a little bit more about that work with you a little bit later. And then finally, COVID-19 really challenged us to think about our grant making. We've always been this funder that's seeding those new ideas, new approaches, innovation. But when the pandemic hit, there was huge basic needs that people needed. And so I chaired the COVID-19 Regional Response Fund that brought multiple funders together during this time. We distributed $7 million in 7 weeks to 230 organizations. And we did that in a very simplified manner that we're all used to. We literally asked 5 questions. Who are you? What are you trying to accomplish? What population do you serve? And please give us the disaggregated data around who you serve. And what basic need are you trying to meet, and what area are you working in? I mean, it wasn't, have you thought about your strategic plan? Or, I mean, people needed the money yesterday. And it was just a different way to do it, right? To respond and get the money out the door and get it where it was needed to meet those basic needs, housing, food, shelter, when this pandemic hit. So I can share a little bit more about that too. And we're always looking at, I think funders immediately go to funding programs, which is direct investment, but philanthropy has a lot of opportunity to build new collaborations and partnerships. Bring people together around the table that haven't talked to each other in the past. And so we're always looking for ways, how do we build collaboratives, partnerships, convening the right people? How can your programmatic pieces lead to informing advocacy? So what I mean by that is we've been funding programs to reduce infant mortality. And in talking with providers and getting in this work, it would make a huge difference if we could push on Ohio Medicaid to extend postpartum coverage a year after birth. Right now, there's some moms who lose their Medicaid coverage 60 days after delivering their baby. When I had my 2 girls, I couldn't even imagine losing my health care coverage in 60 days. If we could get the Ohio Medicaid to extend that to a year, we could help ensure better health for mom and babe, but also help plan for future pregnancies. It would be a huge game changer. And so that's what I mean by your programs can help fuel advocacy and policy efforts, or help inform them at the very least. And then evaluation and learning is key. We never fail, we win or we learn. And so we're always looking to learn and adapt and flex. And sometimes you see things later that you didn't know was possible when you started the initiative. And all of this is grounded with a racial and health equity lens. Every grant we look at is through that lens. And what I'm most proud of is our trust-based philanthropy approach. And what I mean by that is we aren't a foundation. Our initiative is not just to write checks and report back in a year on what you were able to accomplish. It's really working with our grantee and partners and challenging them. What barriers are you facing? How can we work on those together? What opportunities do you see? Where do we need to flex? We're in the trenches with them. And I can tell you that we learn more through a phone call with one of our grantees than we do through a written report. So why should we care about health disparities? There's a number of reasons why, but I'll start with the U.S. The U.S. spends more on health care than any other modern country, as you can see. Yet we fall to the bottom in terms of health and population health. Equity, everybody deserves an equal opportunity to achieve good health. But the playing field isn't equal, and a lot of that has to do with where you live, which I'll also share more about. Another reason is that when you look at health disparities, they account for over $90 billion in excess medical care and over $40 billion in unproductivity. So there's cost here. And that's more important, even more so, and those costs will continue to rise if we don't work on these health disparities, because by 2050, it's estimated that people of color will be 52% of our US population. So we need to figure this out, or the trends are just going to continue. So I'm going to ground ourselves in some definitions here, and I hear people use health inequities and health disparities interchangeably, but they are different. The health disparities are the differences in health status we see across populations, but they are driven by the inequities and the unequal distribution of resources, whether that's social, economic, healthcare, environmental. So the distribution of resources really leads to these health disparities that we see. So what do you think of when you think health disparities? Most people immediately think race and ethnicity, but I'll just call out the fact that you can see health disparities in different types of religion, socioeconomic class, gender, age, sexual orientation, and location. You can see health disparities across all of these. And the social determinants of health, they play a huge role. If you look at a person's health equation, 20% of it is tied to healthcare delivery. Health does not equal healthcare. Genetics is a piece, behaviors is a piece, but the biggest piece of this is those social determinants of health. Do you have access to affordable housing, education, jobs that pay a living wage, community safety, family support or communal support? These are really the key components to a person's health. And when you look across, even within counties, different areas have different opportunities in terms of how social determinants of health come into play. So it really does affect, and when you look at the different areas, those key ingredients vary in quality and vary in abundance significantly. So let's look at the state of Florida. As you can see, there is a blue county right up here that's blue, and their life expectancy can be up to almost 88 years. Right next to it, in Orange County, their life expectancy is 75. That's like, what, 12 years difference, and they're suited right next to each other? So as you can see, zip code can matter more than genetic code. And there is the structural racism component. And that really is that racism is the underlying structural determinant for which all other social determinants come into play and interact with. And so we can't not look at structural racism when we're looking at health disparities. So to achieve health equity, we really need to zero in on those social determinants of health, including poverty, and look at the social determinants of equity, including structural racism. So I did try to prepare and consider my audience in coming down here, and I thought, you know what, I'll check out the Florida State Health Improvement Plan, the SHIP, and see how it compares to Ohio's SHIP. And actually, there's a lot of similarities because your two priorities right now, based on 2019 data, is health equity and maternal and child health. That's what your state is saying is two. And there are other priorities, but those are the top two. And I can tell you the same is with the state of Ohio, these two right here. I also looked at your community health needs assessment that is required every 3 years, and hospital systems need to look at it, they need to respond to it. And it was interesting to me that when I looked at Escambia and Santa Rosa, and they did a community health needs assessment together, they really pulled out those racial and ethnic disparities throughout the report. And so what you find is Black poverty rate is greater in both counties. Black and Hispanic infant deaths are greater in both counties. Specifically to Escambia, there is Black deaths from diabetes are 2 times higher, and death from stroke is 50% greater for Blacks versus whites. In Santa Rosa, you can see that Blacks have 1.5 times more likely to die from a heart attack than whites. And there's others, but I just pull these out because like us, poverty is really high in Cincinnati, so I saw a correlation there. And the infant mortality rates are not equal for Blacks and whites and Hispanics, and we see the same thing in Cincinnati. What I found interesting is when I looked at the community health needs assessment for Walton and Bay, and they did theirs separately, they didn't pull out for me the racial and ethnic disparities like the other counties did. They really focused on those social determinants of health and where they had food deserts within the county. They found that Hispanics and blacks are 2 to 3 times more likely to have no high school diploma. And you can see this income, this social determinant of income coming into play, where those who make between $25,000 and $50,000 are more likely to be overweight or obese. So that's not based on race, that's just based on looking at people's income and their health outcomes, looking at education and health outcomes. And then the Bay County, and you would know more than me, I'm a newbie, but what I understand is they have more rural parts to their county. And so you see that transportation is an issue in some of the Bay Area. They have food deserts, and then Hurricane Michael really hit them hard. So a lot of it was focused around those basic needs. So I just found it really interesting. And there is no like scientific method that around these community health needs assessments. So it's just interesting to look at how people look at different things and what they pull out and what they're focused in on. And you can read more by looking them up. So I thought I'd share a little bit with you. Hopefully it sparks ideas for you as you think about health disparities here in Pensacola, to share some of our work. And I'll start by saying that what we look at a lot is, I would say when BI3 started 10 years ago, we played very much in the midstream. How do we help individuals and address individual needs, which we are still doing? How do we screen patients? But then as we've evolved in our grant making, we also know it's important to start to move upstream, because this is where the community impact happens. And so what are the strategies up in the upstream? So a great example of this, for example, is we work to ensure that moms do not lose their homes when they're late in pregnancy. That adds stress, so we do everything we can to prevent an eviction for a mom who's going to deliver. And we can help individuals that way. But we also invested in a 10-year affordable housing strategy for Cincinnati, because we need more affordable housing in our city. We need to take care of the ones that we have and look for new ways to build more affordable housing, because it's a huge need. So you can play in both, but I think it's important just to think about where you're playing and then what impact you're going to achieve through that. So I'm going to share our journey around infant health and infant mortality. And I will say that this is a black infant death crisis in Cincinnati. Cincinnati is very black and white. So we started by looking at the problem. What did the data say? One striking is Cincinnati has leading healthcare systems. Cincinnati Children's is well renowned. Yet in its backyard, in the neighborhood of Avondale, had one of the worst infant mortality rates in the country. An extreme preterm birth was happening every 26 days. What was the community saying? The community, there was a lot of distrust in that neighborhood with the healthcare system because of discrimination and microaggressions they'd experienced in the past. They were afraid. They were afraid to make that first appointment for prenatal care. I would compare it, let's compare 2 pregnancies to bring this to life. Is when I was pregnant with my 2 girls, after I told my husband, I called my OB-GYN and set up my prenatal appointment. And I drove in my car, and I wasn't worried about when I needed to leave work for my appointments. I slept well at night, not worrying about the roof over my head. And when it came time to delivery, not once did I think I wasn't going to get the quality of care I needed. A woman who lives 20 minutes from where I live, a black woman, can have a very different experience. She's afraid to make that first prenatal appointment because of the discrimination she has faced in the past. She has to take 3 buses to get to her prenatal appointment, and when she gets there 10 minutes late, people are questioning her and upset that she's 10 minutes late. At night, she lies awake because she worries that the landlord is going to evict her. And when it comes time to delivery, she's scared. She's scared that she won't receive the care, and she's afraid that her concerns won't be heard. Those are 2 very different women, 2 very different experiences who don't live all that far apart. Where were the gaps? We saw gaps due to silos. So we had our adult systems who were delivering the babies, not in communication with Cincinnati Children's that were caring for the NICU babies, much less the communication with the community organizations that were working with Avondale and working with moms. There was just all of these silos. And if it was hard for me to navigate, you can imagine how it was for a woman in Avondale. And what organizations are working on this issue? I think it's important when you look at the broader ecosystem. So, what organizations were interested in reducing infant mortality? Who could we bring to the table? Potential partnerships, and then what is that shared vision or goal? So this was the work ahead. Everybody agreed we needed to reduce infant mortality. So we brought competing healthcare systems together, nonprofit organizations like Every Child Succeeds, a home visiting program that was trusted by the Avondale community. We launched Start Strong. And Start Strong was really a pilot that was going to focus on Avondale and start there. And the beautiful thing about a pilot is you can test and try different things and learn, and then hopefully come up with something that you can scale. We did invest dollars on the evaluation piece because it was important. Could we prove statistically significant that this new model we were going to deploy does in fact make a difference? And if you have that statistically significant data, then you have something that you can build on and scale. We knew that we had to start by listening to moms and designing this new model of care in partnership with moms. And then we could test and adapt as we needed and hopefully spread. So what we did, which isn't rocket science, but we put mom and baby at the center. So mom no longer had to figure out all these silos and how to get connected. We put mom and baby in the center and surrounded her what she needs to have a healthy pregnancy. Her basic needs needed to be addressed, but we were seeing moms with health-harming legal needs that providers didn't know how to fix. Mental health needs are great. Coordinated care, community health workers was a key piece to this work, ensuring that we had enough deployed, working with moms, building trust. Help with addiction, which I'll share one of the programs we launched around that. And then this emotional support. In the United States, we are very individualistic. We can do this ourselves. But when it comes to kids and raising kids, I would say a village is much better. That emotional support and feeling like you are part of a community who can help you in time of need, bring it. I will welcome a village any day. And then the culturally competent care. We knew we needed to train providers on implicit bias training and cultural competency to make it a more friendly environment and provide moms with the care they deserve. So the pilot produced great results. A neighborhood that had high extreme preterm births, by launching this model, looking at resolving social determinants of health, we were able to see the reduction go to 0. So there was 0 extreme preterm births for 3 straight years. So we knew we were on to something. We had a pilot in a neighborhood. And we immediately tried to scale it to Price Hill that looks a lot differently from Avondale. Price Hill is Appalachian, and their needs are different, the community's different. And so what we learned early was, okay, this works in Avondale, but we can't just take the same thing and just start replicating it. You really have to start with going to the community and talking with them, saying, we have this new model of care, but let's talk about what are your barriers to make sure that we are removing your barriers and working together on this. So the shared vision was key. Everybody wanted to reduce infant mortality. People have different ways of getting there, but that North Star continued to drive us and helped us overcome obstacles. And spreading the learning. So now that we disrupted the model of care, how do we spread it? So we started the Learning Collaborative that added FQHCs, which are federally qualified health centers. We brought in community organizations that were helping with moms and in that prenatal space, and really launched the Learning Collaborative that could spread across the community, not just be limited to the key partners who developed the model. We had the logic model. We knew what we needed to replicate. We needed community health workers, social workers, early prenatal care. The activities, we needed to wrap around services for mom and put them in the center and coordinate around her. Community engagement. The outputs, what were we going to be able to report on? And it was really the number of women we were serving, the number of women we were screening, the number of referrals to partners. And what I will say is not just the referrals to partners. You can refer a patient somewhere, but it counts whether they show up or not. And so once you refer, like to a legal aid, did that person connect with legal aid, and was their legal issue resolved? If we just stop here, we don't really know what happens. And then the outcomes. We were driven to reduce extreme preterm birth, the leading cause of infant death, racial disparities in extreme preterm birth because black babies were dying at much higher rates than white babies, and we were tracking infant deaths. So what we needed to scale is, could we attract and leverage other dollars? So through the pilot and the results of the pilot and statistically significance, we were able to draw $2 million from Medicaid to expand more community health workers, and we were able to attract $5 million from HRSA to be able to expand into other neighborhoods. And that's one thing when we get into a project, is how can we leverage our funding to attract additional dollars? So we had the model, we were working to spread it, but we really needed to zero in on some of these components. So I'll share 3 examples with you of how we did this. And some of these touch on the video I played earlier in the presentation, but legal aid. So this is T. Elijah, and he was a healthy baby who was born at almost 10 pounds, and his mom, Tamaya, who I got to know. And when Tamaya was coming to her prenatal appointments, Dr. Donraj just noticed she was lethargic and she wasn't as responsive as normal. And she said, "I'm just not sleeping." She said, "I have an electrical issue in my home that I lie awake every night worrying about, because I worry if a fire starts, how am I going to get my kids out, and are we going to be safe?" And so Dr. Donraj, because we started a partnership with the Legal Aid Society, so could provide a warm handoff to legal aid, and they would get in touch with her landlord to say, "You need to fix this." After that phone call from legal aid, it was fixed in 3 days. Mom got sleep. She was sleeping better at night, reduced stress. Baby was born when baby was supposed to be born. Another thing we did was launch a program with First Step Home that keeps mom and baby together while mom overcomes in her addiction. So too often what we were seeing is a mom who is addicted, once she delivered, they would come take the baby away from her because she had an addiction and she needed help, and they would put her somewhere. But this program kept them together. And so by going to First Step Home, mom was able to get the services she needed to start to recover from her addiction, but could still care for her little baby, Mikey. And that's Mikey, who I'm holding. And I was talking to his mom, Jordan, and she said, "You know what, Jill?" She said, I've dealt with addiction. I've been in treatment before, but this is different this time. She's like, "I got this little guy to live for. He wasn't taken from me when I delivered him, and I am gonna work really hard to stay sober and give him the life he deserves." We also were able to, because we're always thinking about sustainability, so when you fund a program, how's it gonna keep going? Well, thankfully, a lot of the services First Step Home were providing were billable by Medicaid, but they didn't have the capacity to be able to do it. So we gave them a grant to build the internal capacity to be able to build Medicaid so they could keep the program going. And Queens Village, that I love. So we merged Start Strong. Start Strong was the evidence-based model. At the same time, Cradle Cincinnati launched as kind of that outward-facing, build awareness around infant mortality, safe sleep. And so we merged the two together. And so Cradle Cincinnati has been leading the scaling to neighborhood. But they launched Queens Village. And what this did was got a group of black women who are willing to come together and say, "We have ideas. We have solutions." And it's built, and there's over 100 women part of this village now. But you can see they work together to solve barriers and solutions, and they just support each other. And I can say that during COVID-19, when they couldn't come together in person, they were having Zoom meetings with babies on their lap. I mean, these women are committed and they feel supported. I've talked to one woman who said, it's just so nice to have somebody to be able to watch the baby for an hour when I got to run somewhere. She's like, I didn't have that before Queens Village started. So I think this is a great model to just, we could do something similar with the Hispanic community and just make sure people have that community. And the racial disparity came to light early on, but you can see, you can see that Black infant mortality in Hamilton County is higher than the national average on this slide through 2018, and I point that out because there's good news on the back end. And you can see it's much higher than the white infant mortality rate versus the Black rate. So there's a huge disparity here. And we're constantly trying to debunk some of the myths that are ingrained. So a lot of people want to say, well, it's the parents' fault. They have unhealthy behaviors. There isn't scientific evidence that said even if you have unhealthy behaviors, that accounts for 100% of a preterm birth. It's not genetics. People think it's genetic. Well, race is a social construct. It's not part of your genes. We're 99.9% the same. So it's not genetics, and there's no scientific evidence that this leads to a difference in delivery. And it's not class, because I can tell you that when you look at the data and you look at a highly educated, high-income Black woman, her health outcomes are worse than a young teenage white person who delivers a baby. So look no further than the experience of Serena Williams had. She knew there was complications after she delivered her baby. She knew that her body wasn't right, and no one would listen to her. So if no one's gonna listen to Serena Williams, now we can understand why there's so much fear from a mom who lives in Avondale that's afraid she's not gonna be heard. And the 9-year results. So this is really exciting to us because 2020, Cradle Cincinnati published data that shows that on record, we now have achieved the lowest infant mortality rate. Not since 1994 has our infant mortality rate been below the national average, and it is today. And this is a lot of the work we've been fueling since 2011 to get to 2020. And a lot of that change is being fueled in our Black neighborhoods where Black infant mortality is decreased by 1/3 over this time period. So there's still a lot of work to do. The disparity still exists, but we are making progress and we are committed to hopefully squashing this disparity. Sustainability. So this is great work, and Cradle Cincinnati is doing a great job. We also partnered with Groundwork Ohio, which is a research and advocacy group in Ohio. As I talked earlier, we know that we need longer coverage for mom after she delivers. She also needs more resources for postpartum depression. And that's really a 2-generational approach if you think about it, because if we can help mom and make sure her mental health is well, she's gonna be a better mom, the child is gonna thrive, it creates a better environment for both. But we need Medicaid to extend that coverage. So we're working with Groundwork Ohio and funding them to do that advocacy on our behalf to push as the Ohio State is formulating their budget. And in recent news, it's very exciting. So Columbus has been piloting the Healthy Beginnings at Home maternal housing program that looks at moms who are worried about being evicted or losing their housing or homeless and are we worry that they're going to have a preterm birth. And so that pilot is going to now be piloted in Cincinnati. So we're really excited about that. And then Optum Health awarded Cradle Cincinnati $400,000 to spread this model to 8 other cities across the country. So I thought that I would pepper in some other things we're doing to look at health disparities and what we're doing. And as I said, COVID-19 really challenged and changed all of us, and it disproportionately affected those, our communities of color. So we have been partnering, and one thing we learned by the COVID-19 Regional Response Fund, what we learned, BI3, was there are a lot of nonprofits that are struggling to pivot to providing online services. They don't have the extra resources to be able to buy more laptops, to train their staff, to train the end users. So we issued a request for proposal, and we kept it really simple like the COVID-19 Response Fund did. And we really prioritized organizations that were serving different populations and those most affected by COVID-19. So we expected maybe we'll get 30 or 40 applications, and we got over 100. And I can tell you the response has been great, that funders just don't do this. Not enough funders invest in capacity, and a lot of these nonprofits are thinking about, okay, well maybe we can have a blend of the way we deliver services even after pre-COVID. So it was really, and we're always just thinking of different ways how to do this work. We've also partnered with our Urban League to ensure equitable distribution of the vaccine, which has its own challenges, but we're trying to work through those. We piloted, so one of our rural hospitals, we started screening for those social determinants of health, and could we reduce those? Even before Centers for Medicare and Medicaid Services awarded their Accountable Health Community grants to do this exact same thing. But we were screening patients, what social determinants of health are affecting them. A lot of it was transportation because it's a rural area. But you know, we partnered with Miami University of Oxford, not to be confused with your Miami University. And we recruited students to help us do the screenings. And what was amazing is we engaged students to talk to the patients. The patients opened up in ways that they were just willing to share with students, honestly, what their barriers were and what they were facing, because I think they felt like no judgment here, right? I'm talking with a student. And so that was really key to us. What was challenging was to sustain it, because right now, as it sits, payers don't want to pay for addressing social determinants of health. And we keep trying to, how do we change that? Because why not invest upstream and prevent more cost, more heartache, worse health outcomes down the road? I don't know. It's a challenge. And then looking ahead, we recently gave a grant to the American Heart Association because what we find is hypertension is correlated with a lot of our pregnancies, at-risk pregnancies. So we're trying to dig into the data to figure out what is that link and intersection, and is there something we can do to intervene. And then, as I mentioned before, Housing Our Future is the 10-year affordable housing strategy in Cincinnati that we were a part of. And then we're very committed to increasing awareness around racial equity and structural racism. And so after COVID hit, we partnered with our Chamber of Commerce to offer a 5 series where we engaged with the business community and we educated them around this and what can they do internally and externally to engage. We launched the School to Work program at TriHealth, our partner healthcare system, that recruits juniors and seniors of Cincinnati public schools, which many of these kids are at risk, into an internship, a 2-year paid internship. And it's amazing because a lot of students think, when you think of healthcare, you think doctors, nurses, the typical roles, but this exposes them to all the different areas of healthcare. They work from the front desk to OB-GYN to pharmacy, and really opens their eyes. And to see the light bulbs that have come on with these amazing students, and most of them want to stay in healthcare some way or go to nursing school. It's just been really amazing to work with these students. And we hope that we can keep them as part of TriHealth, because TriHealth needs to diversify their workforce. We do not mirror the community that we serve. We know that, and it's going to take steps, and it's a long journey, but we're going to get there. And then the Racial Equity Matters is something that our Greater Cincinnati Foundation started, and we are the presenting sponsor of. And this is kind of a 2-part, where groundwork is a 4-hour where it just throws the data at you around the racial health disparities and the racial disparities that we see. And then phase 1 training is a 2-day that really delves into the history of this country and the structural racism that is rooted in our institutions. It's really powerful. And that has led to new conversations. And, you know, as you can see, the respondents, they're affected by it. You know, 94% said it's influencing how they are at home, and 89% says it's influenced how they engage at work. And the thing is everybody has implicit bias. It doesn't make us bad people. Everybody has it. It's just using that power of the pause. I do it all the time. I make a snap judgment about somebody, and then I pause and think, Jill, that's not fair. Like, you know, I'm a product of my society, so, but it's just that pause to think through it. So I'm on a lifelong journey. I want to be a white ally, and I'm committed to doing that. So what can you do? So a lot of people say, Jill, this is great work. You know, what can I do? What can my business do? How do we think about this? And so, you know, identify those key community health measures. Like, what are some of the disparities you're seeing, and what do you want to go after? And what is their community will to go after? So, you know, it takes everybody. So it wasn't hard, well, it was hard, but to create that understanding around who doesn't want more babies to be healthy, to born healthy, and to have a healthy life. And so was that North Star that everybody could come around. Building community support for the issues. Like I said, Todd Portune had launched Cradle Cincinnati, was a huge political advocate for what we were trying to do. And we had nonprofit community, we had the big hospital systems, finding those learning opportunities, learn how existing programs can help inform needed policy and systems change. The biggest thing everybody can do is just educate yourself about race, read books. White fragility was where I started, and it really opened my eyes to the way I walk through life with my white lens. And engage in conversations around racial equity. And it's hard, but it can be really fruitful and move things forward. So I'll leave you with this slide. The major health problems of our time cannot be solved by healthcare alone. They cannot be solved by public health. Collective action is needed, and it is needed now. Thank you.
Yes. Thank you so much. We have collected a lot of questions ahead of time. We had an article that people read about, so I think actually many of these questions are right on, so this is perfect. You know, I was going to ask you how you united all these multiple hospitals and health care organizations under one umbrella, but after I hear you speak, I have to change that because it's so much more than what I would consider healthcare, but you're talking about housing and legal help and so many different areas. How did you gather them together and get them united?
Mm-hmm. Well, we had a little help in doing that. So when we launched the request for proposal, and at that time we were pretty broad and open, send us your ideas, what do you want to try to solve from a health standpoint? And we had Cincinnati Children's respond around reducing infant mortality. And we had Every Child Succeeds, a home visiting program, submit a proposal around reducing infant mortality that had great relationships in the neighborhood of Avondale. And we said, okay, you two need to talk. We need to bring them together. And oh, by the way, it would be really helpful if we brought in TriHealth, who delivers a lot of the babies from Avondale, to try to break down some of those silos. So it really started with the Children's Hospital, our adult hospital that extended into UC Health that also delivers a lot of the babies from Avondale. We had that community, and that's where the pilot started. But I will say when we formed the Learning Collaborative that opened it up to FQHCs, more community-based organizations, that enlarged the table, that got more people engaged. So they helped us, right? Because it wasn't us trying to figure out who wants to do this. We knew Children's wanted to do it. We knew Every Child Succeeds wanted to start to look at this issue, and we brought in the adult healthcare systems, and it kind of grew through the years, but that's where we started and brought everybody around the table.
So we all think we do it best and that our way is the best way. So, I mean, how did you get them to, win them over and say, I mean, you are doing great, but what about this? Was it a completely new plan, or did you go with one of the programs that already existed and just brought more people onto it?
No, they really started by engaging with moms in Avondale. They really wanted to understand, and in Every Child Succeeds, that trusted community-based organization helped build the trust with the providers. So mom said, let's have a meal. Let's have a meal. We want to meet some of the providers who work at the hospital that will be delivering our babies. Let's break bread together. So the physicians thought, this is awesome. This is an opportunity to really educate them around the importance of prenatal care, the vitamins they need to take. And so the providers show up and start talking, and the women are like, whoa, whoa, whoa. Like, we just want to break bread and get to know you. We don't need you to educate us. And so that was really that unique moment of let's just get to know each other. Fast forward a few months later, Dr. Marcotte, who had been at one of those dinners, walked in to deliver a baby at our OB-GYN center, and there was one of the moms he had dinner with. Which was a really great moment for both of them. And he said you could just see mom's face relax when she saw me and I was the one who was gonna deliver her baby. So it really, what I say is it started with the community. You know, they don't need us to solve their problems for them. They need us to engage with them and co-design and really identify. And the silos were an issue, and so were all the barriers, those social barriers.
I loved how you put that, because that was one of the big questions I have for all of our speakers, because it happens so often. You know, in our community, we have so many just well-intended, you know, people, and so many nonprofits and so many boards. I'm on a lot of them, and everybody looks like me. I mean, we do. I mean, that's kind of the elephant in the room. We're same financial standpoint, same race, same background, same everything, and getting people who might need specific services in the room to even figure out what those services might be is the hardest part. I mean, I might throw out something that makes sense to me, but it's so foreign to someone else. So how are you winning over who eventually are the participants in your program, but just the community members to be comfortable not only having the, you know, break bread, but do they then join the task force? Do they join the boards? Or is it, we gathered your input, thank you,
no, we continue to engage with them, and that's where Queens Village has really come into play. You know, they are the people we go to say, here's some of the issues we're seeing, what do you think? Help us, let's think about this together. So they are a tremendous resource for us now. I mean, it's an amazing group, but they're in this, and they do it because they want to see infant mortality reduced. So it really, some of it was organic, but you know, when you go into a community, it's really identifying those trusted partners who already have that trust that then can help build the trust to the healthcare systems. Does that make sense? I mean, it's got to start with somebody you trust. It can't be men in white coats walking into the neighborhood and trying to build that trust.
So in your experience of, and I know infant mortality, we spent a lot of time talking about that, but I know there are many other areas. What are some of the partnerships that were most fruitful for you in your work?
Say again.
So can you pinpoint some partnerships that you might not have thought of that you're like, man, we approached X organization that, you know, is kind of out of the box. It's not a hospital, but they ended up really being the most fruitful for your work.
Yeah, so there's a lot of them, but a great example is Beach Acres Parenting Center works. They have parent coaches. They really try to help families. And so they had this idea, they talked, and our lines are always open. So what we really encourage community organizations, and now they know this about us, but call us and talk to us about your idea before you spend time for filling out a grant application. Like, let's talk about it. And so Beach Acres had started at one practice where they were working with one of our pediatric offices to refer parents to parent coaches. They were screening families for toxic stress in the home environment. And when a family screened high, they were able to provide the warm handoff to the parent coach in the office. And after 3 sessions, we're seeing great improvement in health outcomes and the health of the mental health of the child. So they're like, we want to blow this up. You know, we want to put a parent coach in every pediatric office. And we didn't immediately do that, but we started to scale it up. And when you start to scale up, then you have more data and you have more proof points. And it now is an evidence-based model by the CDC, which is huge for us. The challenge is payers do not want to pay for those preventive services. So Beach Acres is fundraising part of it. And figuring out the model, but that's the challenge. I would say that's the hardest for me, is when you're fueling these new approaches and ideas. So often you run up against nobody wants to pay for it. The hospital system can't do it. Payers don't want to do it, and so you end up with. So sustainability is always something we think about before we give a grant. Like, what are the options here, and what can we try to build over the next 3 years to start to sustain this work?
So we're very blessed here in our community. We recently passed a tax. You're familiar with it, okay? Which Children's Trust is what we're calling it, and there's a pretty significant pot of money. And so one of the concerns that I've heard is, how do we go about getting those innovative, those types of, maybe they're small organizations or someone with just, you know, a nugget of an idea, rather than funneling all the money to people who know how to apply for grants. They know people, they've got it all together. How did you navigate that so that you got the innovative ideas as well as the tried and true that are working?
Yeah. You know, we really leverage our strategic partnership with TriHealth, but we also were, at the time, dependent upon requests for proposals. But what we've learned is the usual suspects were familiar with us. They would respond to our RFP. So when I talked about what we did recently around the capacity building to build nonprofits' capacity to be able to provide services electronically and in this new world, we found that the capacity building piece was so important. And now I lost my train of thought.
That happens to me every time I'm up here. So. I've even forgotten what the question was that I asked you. How you get the new innovative.
So what we did there, because we wanted to reach those grassroots organizations, right? So we leveraged our partnership. We asked the Urban League, will you help us push this RFP out to get to those people that you're connected with that may not know about us? We asked the Center for Closing the Health Gap that does a lot around education with our Black communities. Can you help us push this out to them? And that's how we got New Prospect Baptist Church. And then, you know, the United Way, we said, blast this out to all your agencies. So we try to work through channels that we know to try to push the opportunity down to those grassroots organizations. In terms of innovation, that's more challenging. But when you start to engage in the community, and this is the piece we're still moving towards and trying to figure out, is how do we capture those innovative ideas from those with lived experience, and we're still working on that.
Right. I'm thinking of those, the population we talked about earlier that doesn't have the trust, they haven't seen it work for them. So to get them to invest all that time in putting together a proposal, that must be extremely intimidating. Have you considered, or do you have even someone on staff whose job it is specifically to have outreach to new organizations?
Just hired a person.
Yay.
She's been with us for 2 weeks.
Oh, perfect.
So she's our VP of Strategic Partnerships. And we hope to, a big part of her job will be engaging with the community and starting to build those with the community. And we've done this work up till now with literally 2 people at BI3. So it was more than time to expand our team, and that's the piece we've been missing, and so I hope to do more in that area, and maybe in a few years I can report back.
Well, and I guess I didn't even realize 2 people, so I'm thinking, you know, the Children's Trust, it's a board right now, and it's volunteers, and it's 1 volunteer director until we get off the ground. So there's some lessons maybe that you might have for them as they get started, and this might be one of them, which is invest in
I think what my board would say is that they started the grant making initiative because it's not a foundation. We've just chosen to leverage our investment assets and put them to work today to spur innovation and address health disparities. So when they created the grant making, it was a volunteer board. And so they were really reliant on RFPs. They couldn't engage with the grantees that we do now. So I think they would tell you that hiring me, and I don't say that, I mean hiring anybody, it didn't have to be Jill Miller, but somebody who wakes up every day and thinks about this work, which they couldn't. Many of our board members had jobs and this was something they did for volunteer, but when you have a staff member committed to this work, you can drive it, you can fuel it, you can see opportunities that a volunteer board isn't able to. One thing that we talk a lot about at our board is it's important to have some funding priorities. Like maternal and infant health is one of our priorities. But just because you pick a few key priorities doesn't mean this awesome project comes along that sits outside your priority areas. You can still fund that, right? So boards get really nervous when you start to put them in boxes, but you're never in a box. You can always fund something amazing that comes along. So it's just rewiring the way we think about this work and the way we grant. And I would also say, I would encourage the board and future exec leading it to really think about trying to match the dollars you're giving to what you're asking grantees to do, right? So when you think about outcomes and metrics and what you're asking them to do, does that really match the dollars you're giving them?
It sounds like what you're talking about during COVID, where you reduced it to 5 questions, and that's all you wanted. It was a smaller dollar amount, I assume. So would you have kind of a 50,000 and below gets this type of questionnaire?
So what we did with that, and that was kind of a new space for us, we said, okay, here's 5 things. Pick 3 that you want to measure or count related to this grant. Because what we're hoping then is we can say, okay, these 50 organizations that got funding from us, like we'd like to aggregate it to say, okay, this launch achieved X, Y, and Z, right? But not everybody can measure those 5, so it was like a pick 3 menu. Tell me what you're able to do. But what I spoke about earlier is, Start Strong, that pilot in Avondale launched with a $3 million grant from us. And so we were able to put in place that evaluation component and have people looking at the data and seeing if we were, meeting the mark and moving the needle. But if you give a $10,000 grant to an organization, you can't expect that from them, right? And so that's what I mean. Be mindful of how much you're giving and does that match what you're asking them to deliver on. And what you'll find is a lot of grantees don't ask for what they need. So sometimes we will get an application and we're like, this is amazing, like this is great, but they're not asking for enough. Like they want to do this component of evaluation, they need more funding to be able to bring somebody in and help them think about this. They don't have the capacity to be able to do X. We need to give them more money to do that. So because the nonprofits, they just want the dollars, right? And they think, okay, how can we cut and how can we have a really tight budget so they know that we want to do this work. So we actually, they're surprised by that, but we'll actually say, this is a great idea, let's do it, but you need more money.
Do you have a component, or maybe it happens organically, with the people you have funded where you say, okay, but you have to agree to help X. So small group over here just doesn't have anyone who can help them figure out how to measure. Can you call in someone from one of your other grantees to say, okay, time to give back, you need to help, or do they just organically do that?
We have talked about doing more of that. What has been challenging in the past is a lot of our grants were so unique. I mean, for example, one is we put behavioral health consultants inside our primary care offices so that when adults are having issues with behavioral health, there's someone on site to get a warm handoff, which makes all the difference in the world. So it's really hard to tie the outcomes of that project to say, what we're doing in affordable housing, right? So it becomes more difficult. So we can really show outcomes and outputs on the individual level, but it becomes more challenging when you try to aggregate what you're accomplishing.
You've referenced data a lot, and you even showed our community health needs assessment, which is actually a question I had, so I was so excited. So I was going to ask, what should we be doing to ensure health disparities are considered? You've seen what we're looking at, so maybe the question is, are we missing something? Is there different questions we should be asking to get us data that would be helpful to do this type of work?
Well, I was talking to some people in the room before I started, and I know that they're doing things differently this year as they launch the new community health needs assessment, and are really listening into the community and listening to those with lived experience. And I think that that is so important when you're doing the community health needs assessment. It's one thing to ask people to submit via survey, but it's another thing to really engage and get down in the weeds and figure out what. I mean, I really appreciated when I looked at the community health needs assessment for Escambia and Santa Rosa that they were, it was easy to read because they were literally pulling out, here's the disparities that we're seeing in race and ethnicity, and that was really helpful for me. And then I also loved that the other counties, Bay and Walton, were looking at those social determinants of health. And I think if you tie all that together, that would be ideal, right? And not to say that all of them weren't looking at those things. It's just when I was reading them from an outsider, like it was easy to see in one, and then the other focused more on the social determinants of health, but it was harder for me to see where they were looking at disparities based on race and ethnicity. Okay. Does that make sense?
Yeah.
So I would say the most important thing is just whatever you're looking at and whatever you're collecting, just disaggregate the data. So when you say that, there's an issue with strokes or heart or whatever it is, just make sure you're disaggregating that data to see, okay, how is the white population comparing to the Hispanic population, to the black population, Asian population, right?
I know we, in the media, get those results, and it's a book. It's like it's a gold mine of information. It's like Christmas when it comes, because it gives you all of these story ideas, that ways we can help the community. I was excited, and it was just today actually that we were contacted, or I was, to say, can we help push out to the average person to participate? And I don't recall having seen that before. And was that new? So you can speak up, it's okay. 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 But I've been here 7 years, and I don't recall that piece of it. So we have a big push plan. How do we get this in front of average Joe?
I know in Cincinnati, the health collaborative that leads ours does a nice job at creating one slide that really pulls out the key health disparities in our community. And it's literally something someone could look at for a minute and say, okay, these are our priority areas: infant mortality, behavioral health, addiction. The thing with the community health needs assessment that I'd really challenge communities, and that gets frustrating even in Cincinnati, is that we do this every 3 years, and a lot of times it's like Groundhog's Day. So I bet I can tell you the needs that are gonna hit the top now and predict the future. Because we do these, and then all the hospital systems go off and make their own plans and do their own thing, and then we come back 3 years later. Like, why can't communities use that to say, okay, here's the top needs in this community. Let's all come together and say, let's go after addiction, and let's make a dent over the next 3 years, so that when we do this community health needs assessment, we see change. And that just doesn't happen enough, I don't feel.
I think we're all hoping a little bit that this assessment will be used along with much other data by the Children's Trust, so that they can, because they are pulled together. They're the one place that's pulling everybody together, so there's real opportunity there.
Yeah, I hope this trust, absolutely they can fund smaller programs and grassroots organizations, and that's really important, but go big. Like, zero in on something that you really want to move the dial in the next 10 years for your children here. You're investing in your future. That's amazing. That's amazing that people are willing to increase their taxes to help these children. So think big, right? So that 10 years from now you can say, we did X and Y. And you did a lot of other things too. But that would be awesome, in my opinion.
All right, I want to shift a little bit because we've got about 20 minutes left, and I want to make sure I hit some of these questions, some of these other questions. Are there social detriments of health that are more important than others? And I know you looked at structural racism as kind of that foundation where it all begins. Can you identify any kind of low-hanging fruit opportunities where we can move the needle on that one thing?
I think it depends on your county or your state. In Cincinnati, as I've talked about several times, is we have an affordable housing issue. And this is just Jill Miller's perspective. But housing for me is health. Because if I don't have a house, I don't know how to make life work, right? How do I feed my kids? How do I get them to school? Where do I shower? How do I get ready for work? I mean, think about that. Like, it is your core to making life work. So I would say housing is so important when you think about the social determinants of health. And it may be that affordable housing isn't an issue in other areas, right? But in Cincinnati, I feel like that is a social determinant of health that we really need to figure out.
In your opinion, what's the number one barrier that prevents a community from addressing social disparities of health and getting that change that you talked about? Mm. We've got about 20 minutes, Karen.
It's bigger than BI3. It's bigger than any of us. I mean, we've just created this unequal distribution of resources in various communities. And if you're born in a zip code that you have trouble getting access to healthy foods and you have transportation issues, I mean, that's what I mean by that's not an even playing field for my kids who are growing up who have access to all of that all the time. I mean, we need to change the resources and the way that they're distributed, and that's big. So that is a great question, but I don't know that I have the answer for it.
Well, I know so often we think, I did heading into this, we're talking about disparities in regards to health. All these questions are targeted towards health. Our hospitals in the room, and I think that's one of the big enlightening things for me is they're a partner for sure, but
What's been challenging for me, one of the challenges is, healthcare systems, they're big, they're resourced, right? And so they see, oftentimes it'll be, we can just do this ourselves. It'll get done faster, we can move on it instead of partnering with a community-based organization. But you miss so much. I mean, TriHealth couldn't have changed or decreased the infant mortality rate on its own, no matter what it did internally. So it's really getting healthcare systems, and you saw the health equation, right? 20% of your health is tied to healthcare delivery. It's really getting those healthcare systems, and population health is a big thing. We're trying to move from fee-for-service to population health. But that's only going to work, in my opinion, if you move beyond your hospital walls and partner with community organizations, those organizations that are trusted. And we can really, you can't achieve population health if you ignore the social determinants of health.
So what's the one thing that our healthcare systems have to take away tonight that they need to do? What's their responsibility in all of this? Now that I know it's just not them.
I don't know. I think the deep-seated community health issues has to involve multiple sectors. I mean, Start Strong was a success, and the success we're having is because it's multi-sector. We have politicians who advocate for this. We have the community-based organizations that are working to help moms and partner with our OB-GYN Center. We have our OB-GYN Center engaging in implicit bias training and cultural competency training. I mean, there's all these pieces that need to come together to create real change. And in the public health sector, I mean, you need public health. So, everybody's got to be willing to come together, and that's why I say if you can just find that one thing that your community is ready to do together, yeah, there'll be challenges and barriers, but just keep that North Star and what you're trying to measure collectively, and everybody knows their role. I believe that progress can be made.
I think we had a lot of educators on our call today, because I had several questions in regards to the school system and what is it that schools should be doing, and they were pretty simple things like health classes back in schools. Can that play a role in improving health?
Yes, I believe it does, but I believe that you need to take a step further and engage the parents. So I just learned of a program in Georgia that has Parent University. So not only are they having their kids in school, but they started this parent university where parents learn and they choose what they want to learn. So it's not like you need financial literacy, you need to come to this program. It's really asking the parents, like, what do you want to learn? And it's just created this environment where, you know, they get their own diploma or they get their own certificates, and then that's a big deal because their kids see them engaging and learning, and it just creates that family dynamic that I think you need for a child to thrive. I mean, it can't just be all on the schools to do for 6 or 8 hours a day.
And that was one of the programs in our community that there's discussion already underway on how to get one of those off the ground.
Yeah,
So
I was talking to Julian McQueen.
that's probably, okay, yes, yes. That
So
was it. Okay.
I had lunch with him and his wife today, and I just thought that was a really cool thing. So, but admittedly, we don't play heavily in the education space. Like I shared, the School to Work program is a partnership with Cincinnati Public Schools. So we are offering these internship with them and trying to follow the students even after they graduate is the goal, to see where they go and how it plays out for them. So, but admittedly, what we find in Cincinnati is there's a lot of funders who want to fund education. But there's not so many health funders in Cincinnati. And because of our, you know, unique position with a healthcare system, we can readily pilot and scale new things and form those arranged marriages that need to be made with community-based organizations. So.
How about youth? Are youth involved in any of the programs that you've done in terms of helping steer where the program might go?
No, but it's something that we're exploring. Now that we have our strategic partnerships person on board, that's something that we've discussed. I mean, especially so what's been really cool is Cradle Cincinnati had grant funding, and they let Queens Village decide where those grant funds needed to go. So it's just, you know, changing that power dynamic between the funder and the funded partner, which is really important.
So CivicCon is built on just a really civic group, questions every time. Everybody always wants to know, what can I do personally? What's the thing I need to do to help affect change in this area? And by I mean John Doe sitting in the community somewhere.
Lean in and learn. I mean, what's an issue that you're passionate about? And look at the data and learn more about it and what role you can play or conversation you can initiate. I mean, everybody can lean in and learn, and especially when it comes to structural racism. I mean, I went through that phase 1 training, which was 2 days, and I learned some of this country's history that I never knew before. And it was really powerful and really eye-opening, and they warn you, don't go home and try to talk to your spouse about this, which I did because it was so powerful, and I was like, you won't believe this and what I learned, and he's like, wow, Jill, like, I can't take this all in at the moment, but we've been on a learning journey together, and it's been really awesome as a couple just to evolve around how we think about racial equity, how can we raise our kids. Our kids are 12 and 8, and they know that they have white advantage. They know that they need to work hard, but life is going to come easier for them than their black friends. So I think that we've really taken that on as parents, but I'm really passionate about racial equity. And as I said, I think that is the structural determinant that intersects with all of the social determinants.
And I swear we didn't plan this, but we are going to segue into our next speaker is on exactly that topic. And I don't
Vince
think
Brown?
Yes, she does know. Maybe she does. I didn't think she knew.
So Vince Brown is amazing.
Okay, tell them about Vince Brown.
Vince Brown is amazing. We have engaged him with our OB-GYN Center around cultural competency and implicit bias. And he has a great story. If he doesn't share it, ask him about the biker lady. But, you know, he's been in this DEI work for decades, which has exploded in recent times, but you know, he has implicit bias. Like, he admits this. Everybody does. It doesn't make us bad people. Everybody is product of their society that they live in. So he is amazing. He's engaging. He knows what to do. He's transformed healthcare systems, and he's become a dear friend of mine.
So everybody's going to be on that one. June 14th, 6 p.m. at the Blue Wahoo Stadium.
Yeah,
He's giving me it's a little clicker. It'll come up to tell you. Oh, it's in my pocket. I'm sorry. She threw me for a loop by knowing who Vincent Brown was. I wasn't prepared for that. So I want to, before I jump onto that, I do want to just give you a second to close because I took you down a different path. What's your last message for everybody in this room, everybody online? We've got a lot of people who really are moving the needle in this community. What are your parting words of advice for them?
Come together in new ways with different sectors and go after a problem. And don't let barriers and politics stand in the way. I mean, come together and go after something. You guys have all of the elements here to do that. Doesn't have to be infant mortality, but you can use what I've shared to think about another health disparity. Yeah, go after something.
Everyone here loves like marching orders, so that's perfect. So thank you so much. If we could give Jill a round of applause. She was fantastic. We knew you would be. Quinn has been talking.